right, good morning. I'm Max Mecklenburg, soon to no longer be PGY-3. And this lecture is something that I'm personally interested in, something that's often really boring, but kind of important to our patients. And it's going to be looking at kind of different types of ways of providing health insurance and how a few different countries around the world do it. I'd like to thank Dr. Arakachoa, Dr. Sklar, and I got a bunch of information and inspiration from Physicians for a National Health Program. So the topics I'd like to kind of cover today are the history of health insurance coverage, both internationally and in the US, and then discuss different systems. I'll be using a few different countries as examples of different systems, USA, United Kingdom, Germany, and Canada. Talk a little bit about how those different kinds of systems tend to impact patient outcomes and also costs. And then at the end, just briefly discuss some future directions that health insurance may be going in. I think I should declare not a financial conflict of interest, but I will freely admit to being biased here. These are photos of myself advocating for universal health care coverage in New York State. And I would also advocate for it nationally. All right, so why do I think this topic matters? A lot of the kind of inequalities within healthcare, the maps that you'll see today, for example, a lot of the charts you'll see today are the same charts that you see in every social EM talk. And as probably everybody here knows, the US is worse at pretty much everything when it comes to patient-centered outcomes and costs. And I think this talk today hopes to just examine the side of that that may be attributable to our particular system of health insurance coverage. So some history. There has been for a really long time some kind of system of providing disability coverage or health insurance coverage. All the way back in the Middle Ages, you had what were called tradesmen's guilds that would pool resources and provide payments to the barbers or surgeons or physicians, whatever was available at that time, and also provide direct payments to members who were injured or ill and couldn't work. But the first kind of well-established government-provided universal or attempt at subsidized health insurance was done in Prussia in 1883 under Otto von Bismarck, and he had the Health Insurance Act of 1883, and it was the first governmentally administered social health insurance system. And I think the motivation for this and future governmentally administered health insurance systems is kind of interesting, because there's on the one hand the desire under the Prussian government to provide healthy workers for the state and also to provide competition. Bismarck was very much aware of communist organizing that was happening in his country, and these kinds of guilds and workers' organizations were providing the type of health insurance that he then sort of in competition with them wanted to provide an alternative so that people would be drawn away from those types of mutual aid and self-organizing. So then looking at the United States, in the 19th century, there's basically the kinds of organizations we're talking about. And then in the 1920s and 30s, you had a big rise in the labor movement. By the 1920s, about 1/3 of Americans were covered under different types of mutual aid organizations, the Knights of Labor, the NAACP, the Farmers Alliance. These are all examples of these kind of mutual aid organizations. And at the same time, in the early 30s, you have the rise of private health insurance. First one was in Texas, where hospitals would essentially sell you a plan, and you would pay the hospital directly. And then if you got sick, they would cover your hospital expenses. And so that sort of slowly expanded. And then World War II happens. And that's kind of the catalyst for a lot of the governmentally administered health insurance programs that we have currently around the world. In the United States, it was the Veterans Administration, basically providing the VA that we know today. And it was also in the setting of, you had all these wounded soldiers coming home, and for the first time you had chronic diseases overtaking combat wounds as the main source of casualties or sickness amongst the military. And also, again, I think it's always interesting to look at the context. In the 1930s, you had what were called the bonus marches, and you had all of these really angry soldiers returning from World War I who were not being provided for. And so the government was trying to, again, kind of provide an outlet, competition, you could say, for those kinds of agitations. And then the next really big move in the United States in 1965, Lyndon B. Johnson establishes the Medicaid and Medicare programs that we're all at least somewhat familiar with today, to try to cover the gaps to some extent of this employer-based like Blue Cross Blue Shield system that had developed, and then also those people who were covered by the VA and other sort of scattered programs. But crucially, they set up two programs, Medicare, Medicaid, and established income limits for one, age limits for the other, leaving large parts of the American public uninsured. So that's kind of how we got basically to the system that we have today. So the four basic types of systems that I'll cover are National Health Service, which the United Kingdom is the most famous example of that, single payer systems. I'll be using Canada as an example of single payer systems, multi-payer systems, and mixed systems. Now, it's important to realize the first three systems are all under what we call universal healthcare coverage, which means everybody in the country is covered by some form of health insurance. Mixed systems are, the United States is the most famous example, but mixed systems are actually what we see in most developing countries. Like India, for example, in theory has universal coverage, but in practice has a mixed system like the United States. Most African nations, for example, have mixed systems where a lot of people are not covered. All right. So looking at the first system, National Health Service, I'll go from simplest to most complex. This one is super simple. The government takes your taxes and they run the hospitals, the clinics, the ambulance services. Everything is run under the guise of the NHS, the National Health Service. And you can see an example here of their clinics. The ambulances are also NHS. I thought it was great. The ambulances in the UK have advertisements telling people not to call 911 for non-emergencies. So it's not a problem unique to us. But this is a very straightforward system. It was established also after World War II against a lot of opposition from medical organizations in the UK who thought that it would, take away their autonomy and their profits. But the NHS remains, despite huge funding cuts in the last 10 to 15 years, one of the most popular institutions in the United Kingdom. Britons are very, very fond of the NHS. And they cover dental, ophthalmologic care. It's a pretty broad spectrum. I think it is worth noting that in the last 10 years, there have been big declines in the quality of the NHS. As healthcare costs have risen and the conservative governments there have declined to match funding to increased costs. Wait times in emergency rooms in the UK have gone up. 1 in 10 emergency room visits in the UK now lasts at least 12 hours until dispo, which is probably not as shocking a number to us, but in the UK, that's a new and alarming phenomenon for people. I also thought how many people here have heard of the case of Lucy Letby? Anyone? This was the NICU nurse in the UK who was accused or charged and convicted with being a serial killer, murdering like 12 babies. A really interesting article came out in the New Yorker recently about how maybe she did it, but maybe it was just underfunding and poor staffing at the hospital where she was working at that allowed all these babies to die. And there's no actual direct evidence that she killed any of these babies. And that, anyway, if you get a chance, it's a quick and interesting read that talks about the changes within the NHS using this case as an example. All right, so next simplest system is what we call single payer. This is basically hospitals, clinics are either privately or publicly run, but the only payer, the only one who you bill from is the government, and the government gets its money from taxes and then disperses the money to all the different providers. Canada is just one example. There are 17 countries around the world that have a single payer system, ranging from Japan to Kuwait to Portugal. And then Canada is our next closest neighbor. I think it's a good example because it's fairly similar to us in a lot of ways. So, you know, the benefits here are that you have universal access, there's a greater degree of cost control, and there's a fair amount of relative equity in terms of coverage. Although within Canada, there are big differences between rural areas and urban areas in terms of access and outcomes. You know, some cons are that elective procedures tend to have longer wait times, non-urgent or non-emergent procedures, and imaging can take longer to get for people. All right. Next system would be what's called multi-payer. So this is, Germany is the most famous example of this. And we're, as you can see, kind of going up in complexity. Germany has been sort of patching together their system. But since 2009, everybody in Germany has to be covered by some form of health insurance. And if you are of lower income, below about 70,000 euros, you get automatically enrolled into their version of like Medicaid. But otherwise, you have to either be covered through your employer, it's a 50-50 split, or there's also private coverage that you can purchase separately if you want even more options. But you have to have health insurance. And if you have any trouble getting it, the government will subsidize it. That I put up all of these kind of complicated things to show. On the left are what are called the statutory health insurance plans. These are the nonprofit, governmentally administered, or not governmentally administered, sort of nonprofit, privately administered plans that are subsidized by the government. And on the right are a group of private plans. So a similar number and variety of health insurance plans to the United States, but much more closely regulated. They all have to provide the same basic level of coverage, and they all have to, everybody has to be covered by at least one of them. So, and this obviously provides greater choice, like you can choose in many cases which plan you can get covered under. All right, which brings us to what we are familiar with, which is the most complicated system, which is the United States, what we call a mixed system. So we have private insurance, we have employer-based coverage, we have public programs like Medicare, Medicaid, the VA. I think one thing that's interesting is that estimates of the amount of public money that's paying for health insurance in the United States are something between like 45% is what's directly paid for through the VA, Medicare, Medicaid, and then going up to like 60% when you factor in tax subsidies to employer-based health insurance. So more than half of our healthcare in the United States is already government-administered healthcare and government-funded healthcare. It's just that we then also have this other huge system of private health insurance, which creates the complexity that we see within our system, where your patient's prescription is not covered, or it is covered, it depends on what they have. Then you have people who are completely not covered by any insurance and have to go to the Kings County Clinic. Or in many states where that's not available, they don't go anywhere, and they have longer wait times. So there are some benefits to this system. If you have really good coverage, you tend to have access to elective procedures and imaging much, much quicker than people in places with universal coverage. But you also have to factor in that rapid access to less necessary procedures and imaging comes at the cost of all the people who don't have coverage not having access for emergent or urgent procedures and imaging. And then also there's an argument that gets made that our system drives innovation because profits are so much higher that it pushes our system to innovate better in terms of drugs and medical technologies. And there's a lot of arguments against that as well, which is that a lot of these new medical technologies don't actually improve outcomes significantly. A lot of these pharmaceuticals are actually discovered in university systems or through publicly funded institutions like the CDC, or the NIH, and then just get bought or taken over by private companies, which then charge much higher prices than you would see otherwise. Some disadvantages are that we pay about twice as much per capita as most other countries for our healthcare. It's a very complicated system. We pay about 4 times as much in administrative costs. That's not a huge factor in the overall costs, but it's just, I think, reflective of the complexities of our system, that administrative costs in the United States are about 4 times as high. And then there's the huge, huge inequities in access that you see within the US, which basically account for the majority of our, like that chart at the beginning where our overall life expectancy is worse, our health outcomes are worse. It's not that people who have good health insurance coverage have so much worse outcomes. It's that the average gets dragged down by all the people with poor coverage or no coverage. And it's really, really expensive. As you can see, just between 2007, 2000, and now, all healthcare costs have gone up, but the costs of spending on private health insurance have gone up almost double the amount that the spending on Medicare and Medicaid has gone up. So looking at some cost comparisons between countries. So this is, I wish it was not highlighted this way, but you can see that, the United States compared to Germany, which is the next highest in our cost comparison, almost 100% higher per capita costs. And the majority of that is actually from care. I mean, we are the problem. It's not just administrative costs. It's not just the insurance companies. It's the downstream effects of basically the way that, partially because of partially because of our insurance system, but partially also just because of what Americans have come to expect from the healthcare system. We just have way, way higher inpatient and outpatient costs. But we also have higher administrative costs and all those other things. And then, looking at it relative to our GDP, you can see the chart on the right. You could think of it like, the top left of the chart would be, inefficient and inefficient care, or the top of the chart would be like inefficient care. And then as you go right, it's based on how wealthy the country is. And so for example, the UK has some of the lowest costs per patient despite having a lower GDP than the United States. And the USA is a big, big outlier in terms of how much we spend and compared to our wealth. And then we discussed already administration. And I think another way to look at it is that between 1970 and 2000, the share of the labor, like the share of administrative jobs within the labor force of healthcare, it grew from about 18% to about 27%. So about more than a quarter of jobs in US healthcare is just administrators now. And that's partially because of the complexity of our healthcare system. People have to navigate this. Whereas in Canada, it was 16% in 1970 and 19% in 2000. So still, a 3% absolute rise, but not a over almost 10% absolute rise. And both of those figures, by the way, are excluding actual employees of health insurance companies. We're just talking about healthcare workers. We're not talking about all the people who are employed by health insurance companies, which is far, far, far more in the United States. Another way to look at cost comparisons is just how much are Americans spending? There's nothing really to compare here, unfortunately, because in most countries, there are no out-of-pocket expenditures for healthcare. So there's nothing to compare to. But ours in the United States are climbing really rapidly. And these are, again, not equally distributed, right? African Americans are almost twice as likely as white Americans to have medical debt. Bankruptcy, all these numbers are very unequally distributed within the United States. So how does this affect health, actually? So I want to add the caveat here that it's hard to ascribe outcomes directly to lack of health insurance because there are so many confounding factors that the people in the United States who don't have health insurance are much more likely to have a number of other risk factors for poor health, poverty, all the things that are correlated with poor health outcomes are also correlated with lack of health insurance. But there are studies that try to tease this out. One by Woolhandler et al. Estimated that about 45,000 deaths in the United States, it was a pretty conservative accounting, are directly attributable to lack of health insurance, as opposed to part of a whole constellation of factors. Uninsured people don't get preventative care. 1/3 of uninsured adults have chronic illnesses. I think sometimes in our minds we think, oh, uninsured people, well, maybe not our minds, but in the public imagination, they think, oh, uninsured people are the young people who don't want to buy health insurance on the open market. But about 1/3 of uninsured people in the US are people with chronic illnesses. And, I'm not surprising anybody when I say the United States has the lowest life expectancy at birth, the highest death rates for avoidable and treatable conditions, the highest maternal and infant mortality, and among the highest suicide rates in the world of similarly high income countries, countries with our GDP per capita. And the United States, also has the highest rate of people with multiple chronic medical conditions, highest rates of obesity, nearly twice the average of other high income countries. One plus side is our screening rates for colorectal and breast cancer are significantly higher than other countries, but the utility of that is debatable. And yeah, just to think about other impacts going the other way, the weight, there's a survey, the Commonwealth Fund did a survey internationally asking people, how many of you have waited 4 months or more for an elective surgery? And the US, about 4% of people had to wait 4 months or more, whereas in the UK it was 12% and in Canada it was 18%. So there are significant differences in terms of elective surgeries. If you want to get your non-incarcerated hernia repaired, if you want to get your MRI for your vague neurologic complaints, those kinds of things do take longer. In Germany, the rate of waiting 4 months or more was 0%. So that's an interesting statistic in a place that has a system that's as close to the US as you could get with universal coverage, but more competition amongst health insurance plans. And here we can just in some chart forms, the US and UK, preventable mortality is again things like deaths due to untreated chronic disease, significantly higher in the US. And the graphic representation of the inequalities within coverage in the US, you can see that women of reproductive age are women of color are much more represented within the uninsured group than white Americans. All right. Just looking at how some of this plays out within our local community. I feel like we see this map every time we have a social EM lecture. It's the same map, whether it's asthma rates or whether it's maternal mortality or whether it's, you name the poor health outcome, and this is the map. It's also the map for people without health insurance, not surprisingly. And that's true for both people who are US citizens and people who are not US citizens, although you can see the numbers of undocumented people who are covered by health insurance is pretty abysmal. It's very, very low rates. And I have some other things to mention here. Oops, sorry. There are ways that we try to get around this. We have community clinics. New York City is actually better off than almost anywhere else in the country in terms of providing care for uninsured people, but we're still pretty bad at it, despite our best efforts and despite HHC being an admirable organization trying to bridge that gap. And you see it, right? The obesity rate here is higher than the rest of New York City. You're in East Flatbush. You have high rates of diabetes, hypertension. So just these are all either reflections or along with the lack of healthcare coverage. So where do we go from here? What's the future hold? I think there are both hopeful signs and not so hopeful signs. I think it's worth realizing that healthcare costs are increasing internationally. This is not just a United States problem. This is due to aging populations, due to increasing availability of treatments that cost more, higher expectations from consumers of healthcare. These are not just problems in the United States. They just happen to be a lot worse here, but they are trends that are happening in all of the countries that we just talked about. I think one thing that's happening in the US is you're seeing increasing fragmentation between states in terms of provision of care. We already mentioned in New York, we are on the luckier side of things. There are currently 10 states in the US that for, I guess, let's say on principle, have refused to accept federal government money to expand their Medicaid programs. If those 10 states did so, about 2.3 million people would gain access to health coverage. But currently are not. I'm sorry, I keep going back to this, but this would not be equally distributed, right? Women of reproductive age would see a bigger increase in coverage than older women, unsurprisingly, due to Medicare. Non-Hispanic Black women of reproductive age would see a 50% reduction in lack of insurance in those 10 states. If they were to accept the federal matching funds, or it's not even matching, it's like 10 times as much. If they're willing to put in like, $10, the federal government is willing to give them 100. In New York, there is a project called the New York Health Act, which is what I was holding a sign for at the beginning of the lecture. This is a proposal that's been sort of simmering in the New York State legislature for a long time and keeps getting shut down by the governors, to provide a single payer system within New York State. So that would fully cover preventative care, primary care, inpatient, outpatient, specialty, including long-term care, actually. So even better in some ways than Medicaid. It's estimated that this would, in the long term, save over $100 billion over a 10-year span. That's been audited a bunch of times. And it's something that I personally advocate for, and something you can look up. On the national scale, the discussion has been what's called Medicare for All, which would be expansion of the Medicare system to cover everybody in the US. And that's really all I got. These are some sources. And I would love to hear any questions. I understand we do have to move on though, so. Yes.
Thanks, Max. Really appreciate the information. And clearly, extremely important to understand this and give the opportunity to advocate. What do you? I think I have thoughts on it, but what do you do with this information or kind of this thought process in taking care of your patients in the routine? Like,
sure.
Is there something that learning this and knowing this factors in and how you treat the patient?
Yes, on a day-to-day level, for me personally, it means I wouldn't say playing the system. I would say using the resources that we uniquely have in the emergency room to, because of EMTALA, we have an opportunity that a lot of other services don't have to get patients at least workups. That can be really frustrating sometimes if you then are telling somebody they have a cancer diagnosis and then you're kind of throwing them to the wind, but you can at least try to get things started for them. We have the blessing of being able to work within the HHC system, which despite being overwhelmed and underfunded is available to all our patients. But yeah, I think for me personally, when I'm working, it makes me more likely to do a more intensive workup for patients who I know will not have the opportunity to do that outpatient, especially if I think it could be something that they could actually make something useful out of.
I mean, something for me, and it's changed my practice over the last 10 years in terms of just learning more about this. And I think it's out of scope of what we can talk more about, but just even understanding some of the differences in the insurances. And I do this so much more often now than I ever did. Is just ask the patient if they have insurance. It could be sticky. I usually preface it by like, it doesn't matter for me. I don't care, but I just want to help them figure out the next step. And then having them take out their car, having them take a look at that, and it can change drastically their access and their next steps in terms of trying to get them into our primary care clinic, which is difficult, versus they have a number they can call, get a PCP, probably get an appointment. So something I didn't do often at all in residency, and I think often a reason we go into EM because we don't have to worry about insurance, but it's for the next steps and the overall picture, as you pointed out, it's extremely important.
Yeah. Yeah, Alex.
Two things. One, about the data that came one thing when I was looking at teams that Dr. Polhoff encouraged me to do was the safety factor second when you're trying to prescribe something outpatient to look up this on the patient's insurance formulary, because the difference between prescribing one intranasal steroid and the other that more or less have the same effectiveness could be the difference between a lot of money paid for a medication and not having to pay for it. And with our act is also a really helpful tool. I think also just knowing your local resources that are built to fill the gaps that are very intentionally created by the system, in my opinion, to underserved minoritized and marginalized populations. I think the other question I have for you, Max, is we're seeing the concept of health insurance is, should you get sick, there will be a safety net for you. And this makes a lot of sense in the situation where the primary causes of death, morbidity, and mortality are infectious disease and trauma, which were the primary causes of death, mortality, and morbidity at the time that the insurance system was created. But now that we see kind of all of this shifting towards more cardiometabolic, cancer, and other diseases that are politically determined, how do you think our healthcare system needs to change in terms of the concept of insurance and moving more towards primary care prevention? How can we incorporate that into our emergency department practice, given that we're often seeing people so down the street? How do we make interventions?
Yeah, I mean, I think one fact that's interesting in that context is that the United States has a lower proportion of primary care provider. Like, we have actually more specialists per person than any of the other countries that we discussed. We have, I think, something like 25 to 30% of the primary care providers per person than the other places we talked about. I mean, I think another way to look at it is the financial incentive for a single payer system, because ultimately we can kind of hope for and wish for what we want, but the money part of it would be that under a single payer system, if you can reduce overall costs, you can't shuffle them around. Under our current system, private insurers have an interest in not paying for primary care for as long as possible, because when somebody turns 65, they get covered under Medicare, and all of the resulting comorbidities that come from lack of primary care then get shunted onto Medicare. Whereas if you had a system where all costs are kind of factored in under one umbrella, there would be a much bigger financial incentive to provide preventative care, primary care. As far as us from the ED, when I have the time, I love talking to patients about diet and kind of motivation and all those things. I don't think we're good at that. Just structurally, we're not well placed to be good at that in the ER. But I would love to hear people's in the audience suggestions for how you approach this.
fortunately, maybe we can discuss it more.
Yeah, running out of time.
Thank you.
Yep, thank you guys.